Let's move on really now to the worn knee and the failing knee. We've got someone. Let's talk about meniscal options in someone who's a bit more middle-aged, maybe someone who's had a previous meniscectomy, or he comes to you with a bucket handle tear. Where are you going to go with this?
So, middle-aged man whose meniscus has failed, or
yeah. So let's say he's had a meniscectomy already. So
okay, so the options in our age group,
yeah, our age group.
Okay, so this is a challenging population.
Yeah.
And obviously, ideally, before we get to the point of arthritis associated with losing a meniscus or because the cruciate's deficient, we should consider, if possible, if the amount of damage hasn't progressed too far, to mend some of these things that cause the failing of the knee.
Okay.
So I'm just going to share with you a slide, if I can, which is the philosophies of saving the knee.
Yeah.
And the most important thing here is alignment, varus or valgus. And as important of that is rehabilitation with therapy, getting the knee stable, ligaments, looking after the meniscus, and then looking after the articular cartilage. And that's the pillars of reconstruction.
Yeah.
And in treatment, that tends to lend itself to the osteotomy or the brace, which we'll talk about later. The ligaments being stabilized. Obviously, physio is the most important thing here. Meniscus repair, partial replace or transplant, and we can talk about that. And then dealing with articular cartilage. So dealing with articular cartilage or focal defects is only important once all those other things are taken into account.
Yeah, so it's a holistic, global approach. You're not just isolating things into silos. You're dealing with patients on an individual basis as well. You're looking at what comorbidities, patient factors as well.
Yeah, absolutely. But no one gets any of those operations without rehab.
Right.
Yeah. So, as you know, in the hip, if you do a cartilage operation in the knee or the hip and the alignment's not great, the patient is not going to do well in the midterm.
Yeah.
If I put an ACL into a knee that's very valgus or very varus, then they're not going to do well in the mid to long term. Okay, so we have to correct alignment and we have to really focus on the rehab. But what can we do if someone's lost their meniscus? There are techniques now which are not so new. So from partial meniscal replacement using pieces of tissue. I think one of the ones that the major ones in the world at the moment is ActiFit, made by development surgeons, which we are now using in the UK. And that's for a partial meniscal substitute to particularly on the lateral side or a big defects on the medial side. We can fill the gap, and therefore afford some stability and support. And the other one obviously is a transplant. Now let me just see if I've got a few pictures for you on the ActiFit. 1 second.
Sure. Do you have a cut-off age for transplant or ActiFit? When, what point would you say, I'm sorry, I don't think you're a good candidate for this?
Okay, so I'll come to that question, Rishi, 2 seconds.
Okay.
So this
Just
is
take us through that, please.
That's the ActiFit, and we cut it to size that we need. Okay, here you see the meniscus, a defect in the meniscus, and we sew it in using our normal meniscal suture devices.
Yeah.
Okay, and it looks like that inside the knee. Obviously, articular cartilage is preserved, and that's the indication. If the articular cartilage is relatively preserved, you've got a good margin of meniscus left, we can fill the void with one of these substitutes.
Great. Okay.
So that's the ActiFit. And then obviously we can transplant a meniscus as well. And, we get these meniscus menisci placed on the top of the tibia, and they're made and size matched to the patient.
Right. So you get a good fit.
Yeah. So generally they are for the active patient. the patient who's too good for a knee replacement,
Mm-hmm.
the patient who's had a revision ACL and the ACL failed because the meniscus is missing or they've lost part of that stability. And yeah, it is part of the save the knee procedure or the biological.
Sure.
Yeah.
So you wouldn't say you have an age cutoff per se. So, you know, if a 45-year-old guy comes in with something like the situation, you say good cartilage, good alignment, he'd still be a candidate for something like that?
Yeah, absolutely. So long as his articular cartilage is good,
Yeah,
and you
that's
haven't
the
gone
key. Yeah,
too far
and the
down that.
alignment.
Yeah.
Yeah. Okay. Let's talk a bit more then about alignment, because you've mentioned that, and let's have a chat about what your philosophy and management of that is then, please.
Okay, so you know, Rishi, from my practice that alignment is key.
Yeah.
So people generally who are well aligned, not varus, i.e. bow-legged, not valgus, i.e. knock-kneed, they are tending to do better with all these procedures we intervene with.
Yeah.
There's someone like me who's naturally, it won't come up, but it won't come up, but varus, bow-legged, congenitally so, you know, inherently so. I'm doomed for knee issues. Yeah, so that's my future. I can change it with an osteotomy if I have bad enough symptoms, which I don't, thankfully. But if your alignment is good, these procedures come into play. We can control environment either with an osteotomy surgically or using an unloaded brace, which we can talk about later.
Yeah.
Okay.
Sure.
So paying a particular attention to alignment is key.
Yeah,
and as
absolutely.
you know, in the hip, people with varus pathology can lead to FAI in the hip. And sometimes, you know, people like me who've only got mild OA in my knee might have hip impingement.
Absolutely. And like you say, there's good evidence. We've got good documented evidence of alignment actually in the less than 50 age group having saved themselves from having a knee replacement even up to 15 years later. So, you know, that's a really powerful message about conserving things and getting things going by optimizing your biomechanics. All right. So with sort of, you know, the failing knee or the arthritic knee in our age group, at what point are things too far gone?
So the point to salvage the knee.
Yes.
When their articular cartilage is worn in all compartments.
Okay.
When they have absolutely exhausted physiotherapy and rehabilitation, and they've exhausted all non-operative measures. So we're not going to put a meniscal transplant in someone with bone-on-bone arthritis.
Yeah.
We're not going to do an osteotomy in someone with tri-compartmental disease.
Yes.
We shouldn't be doing ligament reconstructions in people with significant severe arthritis. And obviously, cartilage procedures, obviously, you know, we can't resurface the whole of the knee joint.
No, that's what a knee replacement is.
Yeah, that's what a knee replacement. We resurface it with metal. But so every patient gets treated differently. There are 60-year-olds who would lose their lateral meniscus, have a pristine knee with you know, they might be transplant patients. You never know, particularly on the lateral side.
Yeah.
You know, definitely done ligament reconstructions in patients in their 60s who ski regularly, who don't want to have a brace. You know, it's we can't just cut off an age, their functional needs are, and how much surface damage they have.
Fine. Okay. And let's from a history point of view, what sort of markers, what alarm bells or red flags do you have from that point of view?
Okay, so they're paying pretty much all the time. It's exercise. It's more, their functions are more pain related rather than instability or catching or sports related.
Okay.
You know, someone's much more likely to get a knee salvage procedure if the only time they experience pain is doing sports, etc.
Yeah.
You know, if their general function is that, you know, walking for 5 or 10 minutes at a time is causing agonizing pain, even with our the most arrogant surgeons aren't going to cure that with an arthroscopic keyhole procedure.
No, no, exactly.
So we have to work out patients' realistic outcomes, what their expectations are, what their true function is and what it can be, and whether the tried and tested outcomes of, you know, joint replacement or osteotomy or other procedures, you know, work for them.
Yeah, absolutely. For me, I think if patients come in, they say, I can't sleep at night, I've got this dull pain all the time, I'm fed up with it. To me, I think certainly I'm sort of hearing that sort of story of things are probably too far gone. And you mentioned, you know, I mean, apart from just having pain and dysfunction, stiffness is a key feature in this sort of scenarios. And a lot of patients come in with what we call a fixed flexion deformity. So they come in and they can't walk properly because their leg will physically not straighten out. So they can't get the heel strike, they can't bend. Where are we with non-operative solutions on this?
Okay, so as you know, it's why you've asked me that question. To get a knee replacement under my care, you have to have tried everything.
Yeah.
Fixed flexion is one of the myths that, oh yeah, the patient's got fixed flexion, the physio can't help, time for a knee replacement before the fixed flexion gets worse. Yeah. And actually, I completely couldn't disagree more. What we are bad at in this country in the non-operative treatment of OA is our access to good quality rehab, particularly in the NHS. Okay, so is it a myth that you cannot sort out fixed flexion? Is fixed flexion fixed? No, it's not.
Right.
Okay. With the right physios, and some of them are here, physical manual work on the leg can improve fixed flexion. Okay, so one of the other myths is, you know, getting strength. Yeah, you can't strengthen a knee that doesn't move.
Yeah, absolutely.
Okay? We always, you know, it's the age-old thing, which is, you know, oh, knee physio. What does that mean? Oh, quad strength, VMO. You know, it's not true. The principle here is get the motion back. Yeah. Extension first, then get your flexion. Do whatever it takes to get that. So change your therapist if needed. This is not going to be solved with leaflets and a few exercises on it. Yeah, it's going to take manual therapy and hands-on involvement from the physios. Get the motion back. Get whatever pain relief you need to do that. Then get strength, because you can't strengthen a stiff knee. Absolutely.
So break the vicious cycle, start the therapy, get the movements, fix the fixed flexion, straighten the knee out, build that strength. You think neuromuscular strengthening and sort of these sort of things have a role to play as well?
Yeah, absolutely. And this is why you and I, when someone says, oh, I've done physio, and you go, how much physio have you had? Oh, I saw my physio twice. It ain't good enough.
Yeah, and you know it's not.
You know, you're about to embark on a knee replacement or major surgery.
So yeah, absolutely. I think it's really key to carry on with that sort of.
I think I lost you.
Yeah, I think we're back. Okay, all right.
So on that note, I was just saying that the other worst thing you can do is do not operate on them straight away. And you and I both know people who have knee replacement in our hands, right, never come to us with full extension. They've always got full fixed flexion.
Yes.
And you think deep down, could that fixed flexion have been stopped with physiotherapy? And if that fixed flexion had been improved, would they be on our table?
Yeah, absolutely.
Yeah. And the other thing they shouldn't do is stop adjusting their lifestyle. I think it's the worst advice as well. Keep active, do whatever it takes to avoid a knee replacement, be it physiotherapy and lots of it, maintaining activity, keeping their weight down, using painkillers, using braces, and we can talk about that, and doing those things before they consider knee replacement.
Absolutely.
And
Keep
you
that
and I
level
know
pumping up. Yes.
that, and you and I both know that people say, oh, am I going to be too late for a knee replacement? And the old age, yeah, you're going to be too late. That's not true.
No.
Obviously, some people, if they come in 90-degree fixed with cerebral palsy or something, that might be difficult.
Yeah.
Yeah. But most people, even with a 20-degree fixed flexion, we can get close.
Yes.
And actually, with rehab, you know, we can make them better. But I do think knee replacements are done too quickly in this country.
Yeah. Fair enough. Okay. I agree. In order to get the pain relief and that window of opportunity to start the physio and the rehab, let's talk a bit about analgesia, pain. I mean, you know, at the moment, it's a contentious thing about ibuprofen and non-steroidals. That's now been given an all clear by the government with the COVID virus about a risk of infection. We'll talk a little bit about steroids later after this, but what's your sort of strategy on an analgesic ladder as well?
Okay, so the analgesia should be to sleep and to function, and whatever analgesia you need to give your patients to allow them to respond appropriately to their physiotherapist and to do those exercises is what's required. So simple painkillers that I think you and I are very similar here: paracetamol and Nurofen, and then you work up to codiagamol and naproxen. You and I will completely go against any opioids or neurogenic drugs like the amitriptylines and the gabapentins, because in the US for arthritis, they're really struggling with opioid dependence. And that's just because they still need it after their joint replacements. So whatever it takes, steroid injections to allow patients to do physiotherapy, I am reasonably happy with. And you and I have discussed this. A paper's even come out this month in the JBJS, which is our major orthopedic journal in the UK, saying people who take steroids are more likely to have a knee replacement. Yes, because people have steroid injections for pain associated with knee arthritis. It's a weak thing to say. We know it's true, but there is a little bit of an anti-steroid bandwagon, and potentially at the benefit of people marketing other things. Who knows? That's me just being cynical. But painkillers and steroid injections to do the exercises are very important. But it has to relate. If you have a golden window after your after your painkiller of 6 weeks, then make hay with your therapy. Get your physio to get that fixed flexion away. Get that knee extended. Get on a bicycle. Do your exercises.
Maintain that function. Absolutely.
Yeah. You maintain your function. You will not need us as knee surgeons.
Yeah. What's your take on other injections? So hyaluronic acid, PRP, the adipose tissue sort of options as well. I know there's some things out there.
Yeah, so we discussed this in nearly all of our talks, because people are marketing it for everything. So we know that PRP and HA and probably the fat-based lipogems have some benefit up to about a year. There's no papers that show any meaningful midterm pain relief results.
Yeah, it's all pretty,
Yeah, so yes, people feel that an HA injection or a PRP injection has worked for them in the past, and they bought into it, but we know there's a strong placebo effect as well. But if someone says to me, can I have a PRP injection? I'd rather try that than a knee replacement, because I've done everything else. Then, I think we're game on to have a discussion with the patients on that.
Yes.
There are newer things. People are using placental tissue, amniotic membrane tissue. The new interleukin-1 antagonists might have some encouraging results, but again, nothing beyond 1 year, although they're saying 2 years. So these things, everyone's trying to find the holy grail.
Yeah.
Maybe at the expense of knocking steroids, and that's the thing we have to weigh up as scientists. So
Yeah, as you're saying, it's been an ongoing saga for probably about 30 odd years or something more than that. All right, so look, let's talk about braces then, because actually, you know, going down that sort of conservative route ladder, we've had physio, we've created a window of opportunity with the right analgesic regime, we may have had an injection. After that, where are we with braces? What's the news and updates on that?
So, literally in my hand is this publication we're about to submit from St. Peter's. We looked at, so it's about the unloader brace. And as you know from being with us, that we use it and we're quite strong on non-operative treatments, and the unloader brace features very highly in our menu of painkillers, physiotherapy, injections, and bracing.
And this is NICE approved as well, isn't it?
It's NICE approved, and it's approved by AXA, approved the Osteo unloader brace, and some of the other implant companies, some of the other insurance companies approve these braces as well.
Yeah.
So these braces are not only ideal for arthritis, but we also talk about osteotomy, we mentioned, and possibly unicompartmental knee replacements. People who try the brace is a good trial of these surgeries.
Yeah, exactly.
If you've got a medial compartment OA, and you've got a medial load and it works, okay, eventually we know the osteotomy or the unicompartmental knee replacement will work if done correctly.
It's a perfect try before you buy. Yeah.
Yeah. And so for unicompartmental disease, people who are mechanically varus or valgus, it's a very good option. We've known about it for a while. There's a very good paper from Cardiff that set this ball rolling. We looked at 540 consecutive patients with principally moderate to severe OA. And we had 80.4% who used the brace had no surgery at a mean of 3 years up to 5 years.
Wow, fantastic. Really strong results.
Moderate to severe. 15 people who were listed for knee replacement at the time of giving a brace because their pain was so bad that they were put on the waiting list anyway. Here's a brace just to bide you over.
Right.
Those 15 were removed themselves from the waiting list.
Okay.
Excellent. And what we found, and my colleague David Elliott looked at this, the national figure was for hospitals our size, 485 knee replacements. And we did 344 per annum, which is 141 fewer than perhaps we should be doing based on our size. And that equates to about £920,000 saving a year, even taking into account the cost of the brace.
Fantastic.
So there's your rehab, there's your physio. You know, that's where that money could be better suited, or cancer treatments or something else. So,
so better an investment in conservative management and actually great results. So congratulations on that. That's fantastic. Really good.
Yeah, hopefully get published. But also I know a number of surgeons who wear these braces. I'm varus.
Yes.
I will wear an unloader. I will wear an unloader for many years before I have a knee replacement. That is for certain. As will you.
Absolutely. I just wish I had the medial wear and not the patellofemoral wear, but anyway.
there's new patella braces coming out. So
I'll certainly sign up for that then.
And you need to do some exercise, Rishi Chana.
Yeah. I do my exercises.
Outside, the right kind of exercise, physiotherapy, brace, keep your weight down.
Fine. Okay, duly noted. All right, so where does imaging and sort of MRIs and long leg views come into this sort of situation?
Yeah, so again, prehistorically, people would have an arthroscope and go, yeah, you know, your lateral's okay, we could consider a uni, or we could consider an osteotomy. And now, obviously, we're only doing saving arthroscopy for repair procedures.
Yeah, so there's no role for arthroscopy in an arthritic failed knee.
Correct. There is no role unless they have a significant loose body that's causing locking.
Sure. Okay. Yes.
So now we get long leg x-rays.
Okay.
And the long leg x-rays show us where the weight bearing force through the joint is. And that weight bearing force will tell us whether they're varus or valgus, obviously mechanically. Yeah. And it'll allow us to guide treatment either by, osteotomy, unloader bracing. Obviously, we talked about unicompartment and isolated patellofemoral compartment, because sometimes people have severe wear. You do the long leg film, the alignment's good, you're looking for the wear, and then it's all patellofemoral. Then you get the MRI scan or the skyline views, and the MRI scan can tell you whether there is unicompartmental disease. So I use MRI quite a lot, as you know.
So the MRI does contribute towards that information. Yeah.
So MRI, weight bearing, long leg films.
Okay, sure, fine, all right. And when it finally comes to moving forward, is there much difference in your philosophy between our age group and managing versus the older age group?
Yeah, so our generation versus our parents' generation, I hope they're not the guys being considered for joint biological knee surgery.
Yeah.
My 77-year-old high BMI mom isn't going to have a ligament reconstruction, a meniscal transplant.
No, or an osteotomy.
Or an osteotomy, or a chondral resurfacing procedure, I hope.
Yeah.
And so, those are the guys, again, we must exhaust the non-operative treatments we discussed.
Absolutely. Yeah.
And just to reiterate, there is no evidence for anything other than the simple painkillers, the anti-inflammatories, physiotherapy, the unloader brace, the occasional steroid injection. And I think NICE would also approve, what's that topical anti-inflammatory, and that chili, what's that chili?
Capsaicin cream.
Capsaicin cream.
Yeah.
Nothing in the feet. Yeah.
No.
None of those things are approved for good reason.
Sure.
There's not enough evidence.
Yeah.
Okay. And then we're looking at knee replacements, aren't we? So one, truly someone gets to the bottom of the treatment.
Yeah.
Then we have a serious chat about knee replacement. So even when they get there is a significant milestone or barrier to proceeding to knee replacement. So let me show you something. So let's just go to switch screens a minute, Rishi.
Yeah. Okay.
So that is the tricompartmental arthritis. Trochlear, lateral, medial compartments, all three areas affected, and we can't do anything there. But I want to just show, that's the unloader brace.
Yeah.
Okay, so medial compartment disease, and it shifts the weight onto the outside. And people can play sport in these. Yeah?
Yes.
So I'm just going to come in to 1 second. Sorry, I know you don't want to see
my
face.
So they're pretty comfortable, these braces. They're quite low profile. You can probably, if you had a dress or a skirt, it's not really sort of something one would notice. You could probably put it on a baggy pair of trousers and have the brace underneath it. And
I know surgeons who wear this under their suit.
Yeah.
Okay, so let me just run this. This is a happiness curve after a knee replacement. Okay.
Yeah.
Success following a knee replacement. 10% very, very happy, forgot a knee. I'm going to show you some of those guys. They're my best patients, and they're the guys who run down the corridor.
Yeah.
75 to 80% are good. This number around here, 2 in 10, are not good. That is a real number. So when we talk about knee replacement and hip replacement, we know the people who are very happy after hip replacement are extremely happy.
Yeah.
You have to have done a bad job for them not to be happy. Yeah. So the knee replacement is, you can get 10 very, very good patients to do all their physio, and for whatever reason, for whatever reason, they just don't like it. It's a real number. And if you and I are sitting in an NHS clinic with 30 patients in, and they're all knee replacement, we know we've got 3 of them are going to be miserable.
Yeah.
Yeah. And for no reason. Perfect X-ray is good. They just don't like it. There might be a metal allergy. They weren't prepped. They went too early. They weren't geared up for the physiotherapy.
Yeah. Expectations were not really managed properly. Yes.
And so they're the ones. We've got to pick our winners. Okay. And when it comes to a good result from a knee replacement, we know a great patient, good surgeon, good implant, good physiotherapy.
Yeah, absolutely.
All 4.
That's always the key, isn't it? It's not about the technology you have. Obviously, implants and survivorship come into play.
Yeah.
But it is having the correct operation in the correct patient at the right time, in circumstances, and making sure everyone's happy and knows what's happening and they're on board. What's your sort of knee replacement of choice? Why do you follow that philosophy?
Okay, should we? Yeah, we'll come to that, Rishi. Yeah, and that'll
Yeah.
we can finish. Should we just answer some? Because there's quite a few questions coming in.
Sure.
Okay. Should
Okay.
we have a pause and do some of them?
So what brace are you using? And
okay, so we're using the Ossa Unloader. That's the one that's got the longest history at the moment. That's the one we produced our paper on.
Okay, good. And injections wise, is it steroid or a Cingal or a monovisc injection?
Cingal is a combination of HA and steroid combined. That's a good option.
Yes.
As we said, steroids for pain relief, and HA and PRP, as long as you've got appropriate consent and shared decision making in terms of their efficacy and their long-term results are reasonable.
Fine. And the cream, the capsaicin, it is basically a chili cream or a percutaneous sort of cream. Anything else you wanted to answer?
Harriet, how much prehab should patients do? Where should mobility strength be prior to ACL reconstruction? I asked this in relation to lists being frozen due to COVID. Harriet, good question. So we touched on it last week. So full range of movement, full extension. So anything to do with the knee, be it injury, knee preservation, ligaments, meniscus, knee replacement, get extension, get extension, get extension. Pre-surgery, post-surgery, get extension. Flexion comes last. Nearly every operation I do, I'd like to think a patient can get around a bike before and definitely after surgery.
Mm-hmm.
So how much prehab, particularly now, a lot of bike while they're waiting for their operations, Harriet, and getting the knee calm, getting the effusion down. Was that it, question-wise?
I think so. Yeah, I think we've answered most of the other ones. If there's any other questions, guys, just keep them coming. All right. So why don't you tell us about what sort of knee replacement philosophy you follow and why that is?
Okay, so we use the medial rotation knee. It's MRK, and the SAFE is the newer version, SAIPH. It's made in Surrey, around the corner, British engineered. It's got a failure rate of 2.7%. It's got the best survival on the National Joint Registry. And the reason we use it is because it's designed like the normal knee, and that's a medial ball and socket, and it allows rotation, and it's very, very stable.
Great.
That's MRK knee. And the reason I have that, because we alluded to the fact that 10% of patients are good. Yeah. As in good, as in pain-free. I find in my hands, and when I review other people's results on the medial rotation knees, that they have more people with forgotten knees than any other brand.
So you've shifted the good patients shift more towards that, and hopefully we've minimized the patients who are struggling to an absolute minimum. So we're trying to mitigate bad results here. And okay.
Yeah.
Do you have anything to tell us about
go on.
Your good results?
Oh no, you can see it on my Instagram page, Surrey Knee Surgeon, but all the people, the physios here, from my local hospitals will know that I make all my patients run down the corridor at 6 weeks, and some at 2 weeks. And it's not a joke. So let me just show you some. Not all can, but some can. Okay. She's walking unaided, down crutches. She's rolled her head stocking still down. She's still got the bruises. Okay. And she's happy. And you can see it on her face at the end.
Absolutely.
And this lady is 92. She begged me for a knee replacement, actually, and I thought long and hard of it. But when she walks like that 2 weeks afterwards with no crutches, and
I think you...
it's dead. And then you got these abnormal humans who can do this after a knee replacement. And these are 2 weeks. So this guy's second side, in fairness, so he knew what to expect. But that's just, you know everything's gone right in those cases.
Absolutely.
And I think, Rishi, you've seen this guy before, I think, when you were working with us.
Yeah.
So some people can do, he's had 2 knee replacements now, and he's fit. He goes to the gym every day. He works hard. He's anything's possible. And the reason this knee works is that they feel stable.
Yes, exactly. It's that confidence straight away, a more natural feeling, and they don't have any sort of loss of confidence within it.
But also, I think some of this is in the pre-op conversation. So when we speak to a patient, if we tell them you are going to hurt like mad for the first month afterwards, the first 2 weeks, it's going to be so painful that you wish you'd not had the operation done. And the physios are going to get after you, and we're going to get after you. But if you do it, there is a chance you can be like these guys.
Yeah, exactly. I think it's vital to have set out the patient journey. One of the, because we know what the journey looks like, and a lot of these guys, like you say, first time surgery, they don't know what to expect. They don't know what normal is. And I think managing expectations and telling them this is what's going to happen, and then them seeing that happen and realize it gives them confidence. So, knowing that they're on the fairway, they're recovering well, I think that's absolutely vital.
And, we both work at Sharon Clinic in London and at Nuffield. The patients have in Nuffield in work, the patients have they expect to be sent home at 2 days or on the third day. Where at other hospitals it's 5.6 days. They're in a hospital, they have an ice compression machine, physio lab. They are physio twice a day in the hospitals. They've got outpatient physio booked with a good physio who's going to be hands-on. And by the time they see you in 2 weeks, they're walking. Other than wound issues, that's what you're looking at them for, to make sure they haven't got a complication. And by 6 weeks, they're driven in there. They've got no sticks. And that's what I tell them. That's what you tell them. When I see you next, no sticks, you'll have driven here. And if you're good, I'm going to make you run down the corridor.
Absolutely.
And that's what we do.
So we've got a couple of questions. What's your view on kneeling following a total knee replacement?
Okay, so I have no limitations. So people can kneel. Some people just don't like it, but there's no reason why they can't kneel. Yeah, I have no problem with people kneeling to the garden.
Sure. Okay. And
I have no problem with people running, as long as they realise that if they keep running, they're going to wear it out. Yeah,
exactly. It's about informing them and giving them that education empowerment rather than being dictatorial or telling them what to do. Do you do bilaterals at all? What's your take on bilaterals?
Okay, so I think most people, one of the questions was, do most people end up having bilaterals? Probably.
Yeah.
They have one, and that 80%, the middle population, are so traumatized after one, they give it a good few years before they have another one. And it's like having children. When you have the second one, you've forgotten how bad it was. Well,
yes.
The missus has anyway. And yeah, so but I don't tend to do bilaterals because the risk is quite high.
Yeah, the mortality rate is higher, isn't it?
Yeah, you've got a higher risk of death. It is slight, but you have got a higher risk of death, and so that's why. And ironically, the ones who I do it in are the ones with a higher risk of death, because they're so bad to start with.
Yeah,
That
you want to give
ASA means they've got a very high chance of death just with an anesthetic.
Mm-hmm.
That you might as well risk it only once.
Sure. Yeah.
And then, yeah.
And I think you've got to be careful. I think one of the things is when we're doing the knee replacement, we put instruments for referencing into the medulla, into the long section of the bone, and that can displace bone marrow, which can cause a risk of heart attack or stroke and an inflammatory response. So minimizing that by using extramedullary jigs for the tibia, you know, there's lots of different things that we can do to try and mitigate that risk as and when we're doing them.
Absolutely. And also, you know, there are other techniques. We're going to maybe touch on robots and things, you know, that where we can do cuts without going intramedullary and making big drill holes.
Yeah. So if you've got patients with very specific symptoms or fixed flexion deformity, you can do other things like have a CT scan, a jig that's custom designed for that patient. I know we've both used, even with the LRK, those sort of systems, which is great. And somehow I think, you know, that lack of inflammation I've certainly seen it come through with really good and quick recovery.
Okay. Yeah, I agree with you. And but what I want to say is that we have to be careful about using the robots. The robots aren't going to improve that curve.
No.
The robots are going to improve our surgical skill. Okay, so that curve of success after a knee replacement isn't all down to surgical ability.
No,
yeah, otherwise people
always a big factor.
Otherwise people like you and I would only have great results. Yeah, but it's you know, all those other factors. You can make the most perfect knee replacement, and the patients are still miserable because they're not prepared. They haven't done their prehab or their rehab, or the implant's terrible.
Yeah, yeah. There's always lots of different factors. It's not about any one thing. And as you say, you know, the latest toy or having the latest implant is just one small factor, and most of the times that beneficial result is actually probably minimal. So it's about getting the right operation and the right patient.
Yeah. And I think actually, seriously, joking aside, it's probably not even us. I think the best results from our knee replacements are the people who really engage with their therapists,
yeah,
pre-operatively and post-operatively,
yeah,
tolerate that amount of pain, that they need to do their exercise as well. And if they've got the right mindset, they can make us look very good.
Exactly. Yeah. It's those patients who are well engaged, take an ownership of their situation, and actually they are the center of how we move forward. And you're right, those are always the winner patients, the ones that are a pleasure to see in clinic as well.
Yeah.
Lovely. Well, look, that's been really good. Is there anything else you wanted to have a chat about or discuss or cover? I think we've been pretty comprehensive on the worn knee.
I think we should talk about what we should all be doing now.
Yeah.
Because the chances of all these guys looking after patients at home during COVID, this is not going to be people who are over 70 and under even are not going to be having knee replacements or hip replacements anytime soon.
No.
All right. So what can the physios do? And the physios aren't even hands-on at the moment. So I know some of them are doing really, really good work online, but it ain't quite the same when I'm following up my multi-ligaments and I'm going, yeah, they look good, without assessing any ligaments. It's quite tough. And we've got to think differently on how we assess them and what tests we make them do. So in terms of maybe we could come up with something now to help those patients. I think patients can access braces through their relevant companies.
Yeah,
I know some of the companies we use are, you know, OSSA and stuff, and they have reps who can get braces to patients, or more importantly, via the physios probably.
Yes.
And get these fitted, because fitting these braces can be challenging, and therefore they need to be put on properly. Injections for inflammatory arthritis, I think is where I am at the moment in COVID time. I don't know what your thoughts are, Rishi, on that. Are you happy to give someone who's in agony an injection at the moment? Face
I
to
think, as you
face?
say, you know, if you're looking at the guidelines and things, if we've exhausted absolutely every other possible option, and you've still got a patient who is struggling, then really in a very controlled environment using PPE, using a minimal dose, I think it's a possible option. Yeah, absolutely.
And it's a bit of a travesty for these guys if they can't even get out for their 1
No,
hour
exactly.
a day.
Yeah, and we know that they will then deteriorate and slip down a slippery slope using that sort of vicious cycle model. So we have to break that vicious cycle and get them going.
Correct.
I think,
So,
like you say, you know,
for the physios here, getting those patients moving is key.
Yeah,
because they are going to be sitting at home struggling otherwise.
and I think maybe as surgeons, what we can do is provide a support or a mentorship program for physios and for patients about conveying this sort of information, providing a support network as part of a sort of team group for these people who are struggling.
Okay. Yeah. Look, gyms again. So Save the Joint are giving away free hyaluronic acid injections for 500 patients. I think they need to be referred via their surgeon.
Yes.
So I think they're typically somewhere between £250 and £350 normally. So yeah, contact Save the Joint, I think, or Joint Operations for that. Is that right?
Yes, I think so. Yes.
Okay. Any other questions? So, Rishi, do you want to talk about Da Vinci machines?
Well, it's just not. It's not a Da Vinci machine. I suppose there are robots out there. There are different variable options. The one I use is the Mako. For me, I think it's a useful medium to use for the unicompartmentals in order to achieve that degree of accuracy. But again, it's not the be all and end all. Unless you've got the correct patient and you're doing the right operation at the right time, it's an adjunct. So that's really all I need to say about it.
Okay. Any other things you may know? Okay. That's it, Rishi, I think. That's OA&E done.
Absolutely. Well, look, it's been a real pleasure to do this with you. We've done the hip, we've done the knee, we've done a nice series, and who knows, maybe after that we look at doing something to provide that support mechanism with our health professionals and our patients moving forward. But thank you very much, Paul. It's been fantastic. Nice to see you.
No worries. Thanks, everyone.
We'll keep in touch. Okay, thank you for attending, everyone. Thank you very much. Take care. Bye-bye.
Yeah.